My name is Michael Morgan. I'm a general ophthalmologist, and I work with Ochsner Clinic Foundation in Baton Rouge, Louisiana. Financial disclosure, I do serve as a clinical consultant to eyesight interventional. First thing I'm going to talk about is why do I do canaloplasty? Why did I start doing canaloplasty? Why do I do it? Why do I keep doing it? And I have to say that traditional glaucoma surgery leaves a lot to be desired, in my opinion. I think we're creating a non-physiologic outflow system. We're asking parts of the eye to do jobs it was not intended to do by nature. Conjunctiva was not intended to support fluid flow, and that's what a bleb does. I find that traditional glaucoma surgery has somewhat of a unpredictable postoperative course, which is anxiety-provoking at times. And I find that what appears to be a successful procedure turns out to be a failure over time. And these things are negative, of course, but the complication rate is more of a problem. I think that the TVT study is an excellent example of the complication rate of traditional glaucoma surgery. The trabeculectomy arm had a 27% complication rate, and the tube arm had a 17% complication rate. So for me, if I want to expand glaucoma surgical treatment to patients and I'm going to offer them a 27% complication rate or even a 17% complication rate, I'm going to hold back. I'm not going to feel good about recommending that. And then the severe complication potential is always there. And this is another reason why I'm going to hold back, and I'm going to offer glaucoma surgery as a last resort in this situation. I have experienced these things, choroidal swelling, hypotony, flat chambers. I was discouraged with traditional glaucoma surgery. Now, having said that, I have to say that traditional glaucoma surgery is important. And there are going to be patients who need it, and it's not going to disappear from the face of the earth, certainly not. But it needs to get better. What would happen to the cornea surgeon if he said, I'm not going to do DeSaic? You know, I mean, we have to get better. And so I've had all these. And when I look back at my adventures in traditional surgery, I've had Ahmed valves that I think are perfect. Next day, they're flat. I've had filling the chamber with viscoelastic, and next day, they're flat again. I've had persistent wound leaks that I sew up only to be Seidel negative after I'm done, only to be Seidel positive the next day, and the chamber's flat and the choroid is swelling. And these nightmares are just that, nightmares. I know I don't sleep well when I have a patient whose eye is at risk. So in my mind, traditional glaucoma surgery, though it's important, is not really good enough. Now, why is it not good enough? It's not good enough because we have patients who need treatment that we're not treating. I'm talking about the person who can't afford the medicines, the person who cannot use their medicines, or the person who can't remember if they use their medicines or not. I mean, these are real people who sit in our chair every day, and without doing better glaucoma surgery, we're really not helping them. And SLT is only going to do so much, and it's certainly not enough in all cases. The thing that I've done in the past is if a patient tells me they're out of their drops in 2 weeks and they can't get another bottle until the month is up, I give them an artificial tear and ask them, show me how you put the drop in. And if you do that, I'm sure a number of you have done that, it's not a great idea to do it, it's just a common sense thing. And it's amazing to me to watch these people put a drop in their eye. That's almost like, it could almost be like a canaloplasty test. Put a drop in your eye, show me how you do it, because you'll be stunned. And then you have the other category, which is huge, is patients who are miserable because of medicamentosa. And they wake up miserable, they think about drops all day long, they go to bed miserable. They put glaucoma drops, that makes it worse, they put tears in, they're on restasis. Their whole life is about drops. Now, these people usually have devitalized conjunctiva. They're not good bleb candidates. We need something else. That's what we need. And then the last group of people is, if I have a cataract patient, I always thought, gee, wouldn't it be great if I could do something during cataract surgery which would help get rid of this medication dependence? That would be a great thing. It would be a huge advance. So in 2009, I had got fed up, to be honest with you, and I wanted a better way. So I started doing canaloplasty, and to date I've done well over 100 cases. We had a lot of insurance issues early on. We've worked through a lot of those, thank everybody who participated in that project. But I've used canaloplasty in moderate glaucoma. I've used it in advanced glaucoma. I've used it with and without phacoemulsification. I've used it in patients who are status post express. I've used it in patients status post Ahmed valves. And I have been able to do it in some patients status post trabeculectomy. So what do we know about canaloplasty? There's certain things that happen in ophthalmology, certain studies that are really landmark studies. We have the ETDRS, the DRS. These are big studies, the optic neuritis treatment trial. These are landmark studies in that they change what we do. Now here we have a study by Lewis et al., canaloplasty for primary open-angle glaucoma. And in my mind, this is a landmark study. Everybody's free to decide for themselves because this study has the potential to change what we do. I'm not sure why this hasn't been embraced as a landmark study. What makes a good study? We all learned in medical school. A good study needs to be prospective, multi-center, lots of different surgeons, and we need time. This is not a comparative study. It's not going to there are studies that are done that compare it to trabeculectomy. This is not a comparative study. This is an evaluation study. So we've got all the things we need to have a good study. So what did the study do? It broke patients into 4 categories. First category is patients who were phakic, who underwent a canaloplasty. Second category is pseudophakic eyes that underwent a canaloplasty. Third one is patients who went a simultaneous phaco-canaloplasty. And the fourth group, which is a very interesting group, is patients who had a canaloplasty and then had a cataract surgery later. And we need to know how all these patients do if we're going to decide if the surgery is effective and safe. Here are the groups. The first group here is the patient who were phakic, who went a canaloplasty. We have an N of 82. We have an intraocular pressure before a baseline mean of 23.4 on 2 medications. These patients are down at 6 months, and at 36 months, they're at 15.5 with 0.9 medications. This is phakic eyes. Pseudophakic eyes have similar results, 23.9 on 1.8. We're dropping down to 15.6 on 1.1. So really, there's no significant difference between phakic eyes and pseudophakic eyes in their response to canaloplasty. That's efficacy. We've got another category. This is a very interesting category of the phaco-canaloplasty. It's interesting here because our baseline pressure is 23.5 on 1.5 medicines, but we're dropping even more all the way down to 13.6 on 0.3. This is amazing. This is amazing data. Group 4 are the patients who already had a canaloplasty who subsequently had cataract surgery. You know, you think about these things, you know the patient's going to eventually need cataract surgery. Do you do a canaloplasty? Is it going to work? Well, the answer is in the data, yes, it's going to work. This is the pressure of the patient after the canaloplasty, before the cataract surgery, and look where it is now. This is after the phaco, and the meds are essentially the same. So we can conclude that there's a greater effect with phaco-canaloplasty than when canaloplasty is performed at a different setting, different time. The IOP lowering effect of canaloplasty is maintained after phaco. I think that's a big deal. Now, if the surgery is effective, it also has to be safe. So that means that the patients can't lose vision. So group 1, the phakic eyes, we look at this is a Logmar unit, and I know not everybody's familiar with it, but this is better. The patients got better, the vision actually improved, a slight amount, this is a slight improvement. The pseudophakic eyes dropped a little bit, and if you translate that into Snellen, it's 20/30 to 20/40 plus. It's not felt to be significant clinically. The phaco-canaloplasty improved. Of course, we're taking out a cataract. The cataract patients also improved. We're taking out a cataract. So now we've got safe visual acuity records. So we're not losing vision and we're getting effectiveness. So we're getting close. Now, what about complications? Again, we broke this is interesting. We broke this down into 2 groups here. Groups 1, 2, and 4. So we've separated the phaco-canaloplasty in a different category as the non-combined procedures. Hyphema is a common theme in canaloplasty. I don't think of it as a complication, to be completely honest with you. You're dilating the system, you're lowering the pressure in the eye, there's going to be a little reflux of blood. There's no tearing of there's no PI, there's no tearing of the iris, there's really no traumatic type of hyphema going on here. This all clears, it's of no consequence. I think the elevated intraocular pressures may represent treatment failures. Notice how low it is in the phaco-canaloplasty eyes. These decimated detachments they're really technique dependent, and as you learn, it's not going to happen. I haven't had that happen since the very first day I did them. When I did my first 4, I had 1. And none since then, knock on wood. But what really stands out to me is the lack of hypotony-related complications, 0. 0 early, 0 later. Compare that to a trabeculectomy. So in summary, I would say both phakic and pseudophakic eyes responded well, excellently, and similar to canaloplasty. Canaloplasty was more effective when performed simultaneously with cataract surgery, and the IOP control was maintained or improved in eyes undergoing cataract surgery after canaloplasty, which is a very big point. Cataract surgery either simultaneously or after canaloplasty resulted in improved visual acuity. Neither phakic nor pseudophakic eyes showed a significantly loss of visual acuity after canaloplasty. So we've got safety. And then there's virtually no vision-threatening complications. Again, compare that to other traditional surgeries. So the personal results of me, the procedure that is going to work for Rick Lewis doesn't do me any good if it doesn't work for me. So here's my results. So these are my phaco-canaloplasty results. I have an N of 24. These patients all have 6 months of more follow-up. My average IOP before is 21.6 on 2.2 medications. Postoperatively, 13.3 on 1.1 medications. And this compares favorably to the study. I'm very excited about these results. This makes me want to do more procedures. So I want people to recognize the paradigm shift here. We've needed safe, effective glaucoma surgery for a long time, and it's here. And so this gives us a chance to intervene earlier, and earlier intervention is improved care. We know that from the studies. If we can get in there early, we can save the nerve. We don't have to wait until we have no choice anymore. So what I would say to you is, if you want to know if this is a procedure for you, spend a week going through your day and asking yourself, as you come out of the glaucoma patient's room, would this patient benefit from a safe glaucoma procedure? You will be amazed at how many times you say yes. This procedure has huge applicability, and I really believe the sky's the limit. I would like to talk a little bit about the cataract patient on glaucoma medications. These are really the ideal patients to start on. I tell the patients who are on glaucoma medications that we have an opportunity to open up the drainage system. We can catheterize it similar to how a cardiologist catheterizes a heart artery. We can open it up, and there's a very good chance we can get you off your medicine, certainly off one of them. And the patients will jump at the opportunity, I assure you. They want to get off their medications. There's going to be a catheterization rate for every surgeon. If you look at the original study, it was somewhere in the high 80s and percent-wise. Usually when you get good at this, your catheterization rate exceeds 90%. Some people higher than others, depends a lot on your patients. But I tell the patients that the catheterization rate is not 100%. And so when they go to surgery, they understand they may not get a canaloplasty. This gives you a perfect out if you can't get it done on your early cases. Patients are going to see better, and they're going to be happier anyway. So I can't emphasize enough that the cataract patient on glaucoma medications is really the place you want to start offering this procedure. Again, the results of the phaco will please the patient. Do not bring a patient to surgery in your first cases who is in dire need of IOP lowering. Do not bring a patient with just a small field left. These are the wrong patients. They have tighter systems. The research has shown that. It's harder to get the catheter through. And although you're going to want to attempt this down the road, if you're just starting the procedure, you don't want to start on those patients. Set yourself up for success by picking patients who will do well. You're not going to be able to do this procedure without making a commitment to doing it. It's going to take a decision on your part. What it took for me was getting fed up with traditional glaucoma surgery. That's really what it took for me, and I had disasters occasionally, maybe once or twice a year, and I finally got my post-express disaster, and I just didn't want to do it anymore. I still do them in some cases, however. So I would say to you, schedule 3 cases early on your first day. Follow that with 3 more as soon as you can. The sooner you start getting these cases done, the better. And with respect to the learning curve, it is wrong to say I'm going to fail and my patients aren't going to do well until I get through the learning curve. I had a patient come in last week who was in my first 4 cases that I'd done. His pressure is 15. He's on 1 medication. That's a success. And you can get successes on your first OR day, but you'll get better at it as time goes on. And again, focus on the cataract patient. The eye science people are amazing, and the clinical instructors are fabulous. You will learn so much from them, and they will network you with other doctors. They will help put you in touch with people and help you learn. You will learn so much. Trust the data. The procedure really does work. You've seen my data. It compares favorably to the studies. Network with colleagues. Now, if you study the surgical videos that are out there, I think that's a great way to get started. The surgical videos, there are plenty of them. Mahmoud has some. David has some very good ones. Mahmoud's are great. I made one. There's some from a fellow from Germany named Sharoth. If you do look at my video, pay attention to every word I say, because every word was carefully chosen. And remember, nothing ventured, nothing gained. I would say that the most important thing to learning canaloplasty is not being a super surgeon. It's just being a careful surgeon who pays attention to detail, who wants to learn the procedure. That's what you need. You just need to have a desire to learn the procedure. The support is there, and if you want to learn the procedure, you will have every opportunity to do that. I consider it to be similar in difficulty to some of the more advanced cataracts that we do, and so it is a very doable procedure. Mahmoud has already talked about the postoperative management. I agree with him. I use a lot of Lotamax. You watch for IOP spikes, and it is so much less time consuming. You're going to spend 15 minutes more in the OR on a canaloplasty patient than on an express or on a trabeculectomy, but you are going to save an enormous amount of time postoperatively, particularly if you can avoid those disasters which come about once or twice a year. Adopting canaloplasty will give you a greater opportunity to treat people. People will get better, patients will get better, you will improve the lives of your patients. You will be able to do this, and so you will increase your surgical volume. There's no question. People get the word out. The word gets out that you're doing this new glaucoma procedure. Patients want it. They will find you. I have found patients, now I have patients crossing state lines to come see me. And this will happen to you as well. This is absolutely a fabulous procedure with a fabulous applicability. There's no question. I'm very excited to be doing it, and I'm just delighted with it. Traditional surgical interventions, as Mahmoud has already said, are still available. There are some misconceptions about that. I'll leave it at that. You definitely can do whatever you need to do afterwards should the need arise. And I'd like to turn it over to David.